Right, we have some about 20 minutes for the audience to ask some questions, and as well as we have some ARS. So the audience have not had a chance to ask any questions on the hip. So please line up the mics on the floor. And can I start off by asking Bill? Bill, you showed us a case in which, one of the flaps was interfering and then that caused a recurrent dislocation. And suppose if you are operating for recurrent dislocation, would you add a dual mobility even though you identified some other cause as the factor causing you the recurrent dislocation? Would you just add in the dual mobility?
Yes, I think an increase diameter increases stability. And so you'd use as many tricks as you can when you're doing a revision for dislocation. So yes, I now routinely, if I'm changing the cup, I would routinely use a dual mobility cup in a revision for dislocation, or even if it's just a revision for any reason, we'll often use a dual mobility to reduce the risk of dislocation, as well as the other things that we do.
Yeah. Would the panel agree to that? Yeah, so as a message, if you are operating for recurrent dislocation, and even if you find a specific cause like a malposition component, for example, retrovered cup, if you just correct that, that's not a great idea. I mean, you may correct it, we are very lucky, but it's best to deploy all the tools that you have. You probably would have to add a dual mobility. If the trochanter is bald, probably add a transfer, whatever it is, all that you have in your hands. Okay, and mic 4, please. Mic 4.
Hello. My question to the panel is, what is your preferred method for management of abductor deficiency?
Okay, so we'll ask the Indian surgeons, Rajesh. Rajesh is the one who spoke on it, yeah.
I'm the one who spoke on it, and actually
So let's take a more practical situation. You open the hip up, you find the abductor is intact, but the trochanter is bald. But the whole abductor is not gone, still there. Would you still add a transfer?
No, I think that I would like to repair it, create a trough and create or transosseous repair. That's what you would like to do. The transfers are when you can't do the direct muscle repair. But if you need a muscle transfer, there are only two, either the white sides with the gluteus maximus with or without the tensor fascia lata, and the other is mobilizing the whole vastus lateralis up after releasing it and mobilizing it superiorly, attaching it. Those are the only two muscle transfers which really work.
Yeah, white sides technique looks very complicated. He described a lot of steps, but most surgeons would just take the anterior part of the gluteus maximus and put it. Would you agree with that? Yep. You don't have to do anything complex like what white sides, but the concept remains very same. Just the anterior part of the gluteus maximus, you put it on into the GT. Yeah, Bill?
There's two major problems with abductor deficiency. One is that they have a limp, and the other is that the hip will be unstable and dislocate. So we would think about using a constrained liner if there's abductor deficiency to reduce the risk of dislocation. And the limp is, not terrible. Patients can walk with an abductor deficiency with a lurch. And so
I think what Professor Malhotra said, he will add a dual mobility. In addition to that, he will do a transfer. Am I right? Yeah, I think if you have a complete abductor deficiency, you must add some kind of a constrained cup or a dual mobility. Yes. In addition to that, they are doing the transfers. Yeah. Mic 3, please.
In a scenario where the abductors are too tight and you're not able to bring them down even after extensive release, what's option you left for you?
You mean sort of a high riding hip you have and you're not able to bring it down?
Yeah.
Okay, so we'll ask the panel, Rajesh.
I will. For me, the implant I prefer is SROM, so I'll have no hesitation in doing a shortening, subtrochanteric shortening, put in an SROM and bring it down.
Right. Okay, Bill.
So subtrochanteric shortening won't help you with the abductor tightness because the abductors attach, but it does help you with the tightness of the other structures around the hip. I think if you've got a high-riding dysplastic hip, you get these sort of osteophytes or this extra bone that pushes out, that tense the abductors, so you can take all that. Once you've got your cup in, you can use a saw or an osteotome and remove all the extra bone that's sticking out. And then you can release some of the abductors off the iliac crest, and that will help it to come down a little bit as well. And also, when you have a dysplasia and you bring it down, you're not bringing it down, you're bringing it down and medial. So the abductors tend to swing in. So it's usually possible to get it reduced.
Yes, Dr. Arora?
So if you find it very difficult to bring it down, then think about a sciatic nerve also. So don't hesitate to add shortening rather than trying to bring it down by release. That is what I think.
Right. So in summary, there are two types of shortening. Sometimes it occurs due to scarring around the hip, typically a post-septic, where a subtrochanteric osteotomy may not help you much. That's what Bill, so the tricks here are a very good release, extensive release. You may choose to keep a little high hip center. You may choose to sink your stem down. All that will help in your, reducing the hip. Contrast to Crow 4, where the primary thing that you will do is a subtrochanteric osteotomy, because the gluteus maximus is not tight. It is the adductors, the thigh muscles are tight. So for that, a subtrochanteric osteotomy is the way to go. Does that answer your question?
Vijay, I'll just add one thing.
Yes, please.
I think more than 3 centimeter getting it down, as you rightly said, dissect out sciatic nerve. Because there has to be something in between. You can't just keep on getting it down.
3.5, 4 centimeters is the maximum that you can do without a subtrochanteric shortening osteotomy. Yeah, point well taken.
Is there any role of jetplasty in the tendons?
I think people would not do it as a rule. You wouldn't lengthen the gluteus medius. I'm sure the panel would agree to that. It's not like other tendons where you lengthen the tendon. Yeah.
How much limb length discrepancy you can expect after doing a subtrochanteric osteotomy, sir?
From 5 you're asking, is it?
Yeah.
Right. So
you have done a subtrochanteric osteotomy about for a 7
here's a high riding hip. You've done a subtrochanteric osteotomy, and how much shortening is acceptable? That's the question.
I don't think the subtrochanteric shortening by itself gives rise to any shortening, because it helps you bring down the hip, and we anyway counsel the patient that we will not be able to correct more than 4 centimeter of shortening. So, I mean, whatever is left, give or take half a centimeter is all that is required. I mean, it's really doesn't cause a whole lot more shortening. It's a misconception that if you do a subtrochanteric shortening, you will get this thing, because that it helps to bring the hip down, and I don't think you add a few millimeters, more than a few
Neil wants to
millimeters.
say something, yeah?
Well, there's two considerations. One is the tension of the hip, and the other is the limb length on the other side. So it depends on your other hip. If your other hip is longer or shorter, you can adjust that so that you may be able to get equal leg lengths.
Yeah. Neil?
Yeah. One of the other things is that I think that people have compensated for this short leg for a long time.
Absolutely, yeah.
So I think if you make them perfect, they're going to feel excessively long.
Absolutely.
So I'm looking at 70 or 80% of the leg length of what I'm trying to get back. If I get that, they'll feel perfect, and they'll say, oh, you know what, this is great.
Yeah.
Right? So
Vijay possibly is asking whether how much overriding of after subtrochanteric osteotomy you can get.
No. He's asking about the length. So in summary, overall the limb will get lengthened, but it will not lengthen to the other side. So never make a mistake of telling the patient pre-op that your limb will be short. As Neil said, they'll all be very happy and they will not notice that limb length discrepancy. They have been used to a very short limb for a long time. You have lengthened the limb overall, but you're not equal to the other side. They will not notice it. They'll be very happy. Don't tell them that they're going to land up short. Microphone 3, please.
Yeah. If there is a limb length about maybe 2 centimeter, 1.5 centimeter on table, what you will do?
Table means what? Pre-op.
Pardon?
By the table means what do you mean? Your pre-op he has got 2
I think he's
centimeters.
talking about after trial.
Per operative on trial. I mean, you have finished the operation and you are seeing that your limb will lengthen there, because many times it happens.
Okay, lengthen by 2 centimeters.
Maybe 2 centimeters.
Yeah, that's rather rare, but we'll ask let's say 1 centimeter, yeah.
Okay, 1 centimeter, fine.
Okay, we'll go from this side. So trial reduction tells you that you are 1 centimeter long.
So I think intraoperative, you got to figure out why they're long.
Yeah.
So have you lengthened them because you haven't made your neck cut right, you haven't put the socket in the right spot? I would look at potentially offset. If I need that stability, but I don't want to lengthen that much, can that patient tolerate a little bit more offset?
No, but I think the thing which is governing is the tension on the soft tissue there only. Your offset is fine there. You can, up to some extent, you can lengthen, stop the lengthening. But you have to have the tension at the abductor tension to keep the head in the acetabulum. So that will be loose if you keep it less there. So there has to be some tension on the soft tissue which keeps the things there.
Now there are so there are 2 things here. Some patients are lax, and not all patients will need the same tightness. So a good way is to look at the laxity before you dislocate the hip. Some people, especially dysplastic hips, will be very lax, and for them, if you apply a routine techniques of creating the tightness, you are going to increase the length significantly. But that's one scenario. Other scenario I want to ask the panelists, very common in India. You have this small female patient with a low offset, and you have gone very low down in your cut. You have used the lowest head available to you. Still your offset is big. What will you do? Arora?
So we tend to sink the stem a little bit down. And
Yeah, we have done that.
So if there is no implant available, you can't help the situation, right?
Anil, if you sink it down, then it will be loose. Your abductor things will
No,
be
that's
loose.
what we're saying. That's a different scenario. That's probably due to tissue laxity. So we're going to another scenario now.
See,
where
what you are talking of is sometimes you mistake offset for length, right? If you are not restored the offset and you are trying to increase the neck length, you are inadvertently increasing the offset and length also, both the sides.
Anil, most of the time offset is you are using for the shortening only. For the shortening.
Offset is for abductor tension.
Yeah. Abductor, you know, for the abductor
Offset is for
tightening.
lateralization. And
Lateralization only.
Yeah.
But if you have lengthening, my question is for the lengthening. If you are lengthening it, if you sink it more, this your soft tissue will become lax.
Can I take the question 3?
Yes, please, yeah.
So if you have normal anatomy at the beginning, and then you have arthritis, you'll have a little bit of shortening. If then you do a hip replacement, if it's too long, then it will be too tight. And so you can shorten your hip to the correct anatomic length before the arthritis, and your tension should be perfect. If you had normal anatomy to start with.
I think that answers the question. That's exactly what you should do, yeah, okay? So this is another scenario that we're talking about here. Say a low offset patient, yes, Rajesh. Yeah.
I want to ask you the same question which you are asking, which is not at all uncommon. Small lady, you have sunk the hip in, and you realize that the offset is not enough because trochanter is way up. It's slightly higher than the center of the hip head. So let me ask you, would you do a trochanteric advancement? Because I showed that in my picture, but I don't know how many surgeons actually divide the trochanter and advance it.
As I said, we face this situation commonly, especially when you use a corail stem, because the homothetic stem, the offset is same almost to the entire range. So in low offset patients, you're going to run into problem if you use a corail type stem. And if you add a ceramic head, which doesn't have a minus option, still same problem gets compounded, yeah. I would change my stem, it's as simple as I'll use a cone Wagner. That's what I do, but I like to ask the panel, yeah.
You could make sure your cup is medial.
Yeah, we've done all that. We're talking about very low offset patients. Very common in our population.
You need a different stem.
Sorry?
You need a different stem.
Different stem. You need a S-ROM stem or a cone Wagner. One of them you need. You cannot manage the situation with the usual things that you have. So if you have a low offset stem, keep some other low offset system handy. Otherwise, you're not going to manage that. Yeah.
You didn't answer whether you have ever done a trochanteric advancement.
No, I have not done a trochanteric advancement. No, I have not done. Okay, for Ravi.
Good afternoon, Dr. Ravi from Sparsh. I would like to ask the panel, what is the objective assessment tool to detect power and bulkiness of the abductors preoperatively in both primary and revision scenario?
You want to assess the power?
Yeah, assess the girth of the abductor deficiency or abductor thickness functionality. Any tool.
Yeah.
We do is clinically.
The first test is to observe the gait and see if they have a lurch. Yeah. Second test is Trendelenburg test. Have them stand on one leg and see if the pelvis sags. Third test is to lay the patient laterally with that side up and ask them to abduct against gravity. And if they have ankylosing spondylitis and they have a fused hip and they can't move their hip, you can palpate the muscle and ask them to abduct, and you will feel the muscle contract even if the leg doesn't move. And then the next thing you could do is an MRI scan and look at the muscle on the MRI scan.
Yeah, I think that's a comprehensive answer to that, yeah.
Thank you.
We'll come to Dr. Arora's periprosthetic fractures, yeah. So we have a situation here, you've done an unsimmered hip, primary hip, and 2 weeks later the patient has got a trivial fall, just stumbles, and you have a periprosthetic fracture involving on the medial side, involving the lesser trochanter, like that. So what are you going to do about that, Dr. Arora?
So first thing we need to ensure the stem is stable or no, because...
You only have done the stem.
So after fall, one is I might have cracked there and did not detect it at the time of surgery. It got complete later on. Or second
Sorry, I didn't get that. What did you say? Yeah.
So the first chance is that while impacting my stem at the time of index surgery, I might have cracked the medial cortex.
So you're saying, yeah.
Did not detect it.
That's right.
Patient had a minimal fall or no fall at all. And the fracture got completed, and now this situation is unstable.
So this fracture pattern that you have, the medial side fracture with the lesser trochanter in the middle large fragment, is always an introp fracture that is missed, and the patient presents with a stumble fall, always an introp fracture. Okay, so how are you going to manage that?
So I will not hesitate to go in again and put another stem, distal fixation stem, and stabilize and fix with the circulage wire.
If you find that the stem is stable, would you still go ahead?
It's very difficult to say if you go by literature, because I don't have massive experience of these fractures, but if you go by literature, it's very difficult to say whether it's stable or unstable.
So what about the rest of the panel? What would they do in that situation?
If the calcar crack is more than 2 millimeter, it requires grafting. If it is stable, don't do anything. If it is not, add a stainless steel wire.
It depends how far the femoral component has moved, because if it's gone distally, you've lost length.
Yep.
And you can't see the rotation. So usually they posteriorly rotate. The femoral head goes backwards. So I think they all need revision.
Yeah. So I think the take-home message is that type of fracture will always need revision with a distal fixing stem. These are not to be mistaken for the calcar fractures, which typically do well with the conservative management. This needs to be perioperative fracture. If I find it on the table also, I would do distal fixing stem. Okay.
Hello. Sorry.
4, yeah. Mic 4, please. Yeah.
Me? Yes. Coming back to the same question Dr. Vipin Tyagi asked. If during the trial, finishing the surgery, you find 1 centimeter, for example, lengthening, there are 2 situations. The same smaller neck length with a more offset process. If you don't have that, the same neck length, you sink it more, abductor will be more stronger, and your lengthening will be reduced.
Yeah,
your opinion.
We take the point, yeah. If you can sink the stem, that's very good, yeah. We take that point, yeah. We have to move on to the ARS questions. My apologies. Okay, last question, 5, yeah.
Yeah, so last 2 questions we can take.
What is the most common method of using a limb-length discrepancy intraop? The Ranawat technique or using a suture at what you told Bose?
There are many techniques that you can use, whatever is comfortable. Vaidya uses the Ranawat technique. I use a different technique, but whatever you're comfortable with and are able to reproduce post-op, I suppose that's fine, yeah. Okay? So shall we have the ARS, please?
Yeah, last question. We'll take one last question while they're setting it up.
Yeah, 3. That will be the last question, please.
Sir, my question is related to dislocation. It has been seen that after fracture neck of femur, doing a THA has a more dislocation rate than doing a hemiarthroplasty. The soft tissue injury is the reason, or the larger head in comparison to THA in hemiarthroplasty is the advantage for low rate of dislocation?
So you want to know why a bipolar has a lower rate of dislocation than a THR in fracture neck of femur?
In acute fracture neck of femur.
Yeah.
Because it's a larger diameter head. Larger diameter heads are more stable.
Okay. Yeah. So the published incidence of dislocation of THR in fracture neck of femur is about 10%. It's about 10%. So you got to keep that in mind, that when you're operating on a fracture neck of femur, THR, you are handling a high risk situation there, yeah, okay?
But doing a THA after bipolar revision has more, again, high rate of dislocation.
Is it published like that? Not sure.
Can I comment on this? One of the reasons of why the dislocation rate is higher in the fracture neck of the femur is that in fracture neck of the femur, you have the normal capsule. It is not a contracted capsule. While in an arthritic situation, the capsule is contracted, and that gives some kind of a stability.
Yeah, we understand that. But the question was why bipolar is more stable in that particular situation. Yeah, so because of the larger head. Yeah, we take that point. Shall we go to the ARS, please?
Just last question, please.
The ARS, yeah, go on. Yeah.
Any role, Mr. Arora, any role of Dacron mesh or Prolin mesh in abductor insufficiency?
That has been described, and all those are reinforcement methods. If you have done direct muscle repair, you can repair it with the Prolin mesh, or you can reinforce it with the Achilles tendon graft. So yes, it is reported, but all these are roughly have about 50% success rate. So, and you should be very careful about the rehab. Protect them for a long time. Ask them to use a cane for at least 6 months.
Right. Okay. So we have a little time. So we have about 9 ARS questions. So your keypads are on the back of your chair. Kindly do use them. It's very important that we get this feedback on the ARS.
Yeah, requesting all of you to please open up your ARS pads. They are behind you or the seat, and all of you should vote because it's important for us. There are going to be some decisions made depending on your responses. So please, all of you vote. After this is lunch, but we are going to start right on time because many people have flights to catch.
Yeah,
One last announcement is that the book on comprehensive guide for hip and knee arthroplasty is available down at a 30% discount. Those who want to buy it can buy it.
So we'll run through this quickly. So the first ARS question is approach, which is your, so in India we're looking at the prevalence of the various approaches. The postlateral, the lateral. The lateral refers to the hard hinge. The anterolateral is something like the Watson-Jones. And you have direct anterior, DAA. Okay, so we have that. So it starts now, yeah, okay. in India, it seems to be the postlateral is the more common. And direct anterior is Bose here. It's just one. It's only 1%. Yeah, it's very strange because all over the world the direct anterior has caught on like a wildfire. In India, it hasn't done so. So that's where we stand today in 2019. Good. So we will. And hard hinge is 15%. Okay. I think it's losing out. Hard hinge world over is losing out, and direct anterior is gaining. Posterior is also gaining, I think. Okay, so we go on to the next one. So this is the issue that I raised in reference to direct anterior approach. World over, it's been really catching on, but not catching on in India. We want to know why. So the following are your options. You need more evidence to get convinced about DAA. You think the training has been inadequate. You don't want to at all, and you probably will think in future. So we want to know this is where you stand today. Okay, shall we start the voting, please? So I'm really surprised at that. All you need is more training. Okay. So this is for the senior surgeons and the companies to listen to.
More such conferences and live surgeries and hands-on next time.
So maybe we should have more DAA workshops and things like that. I'm truly surprised at this answer. I thought you would say either more evidence or don't want to. That's what I thought. Okay? Right. We'll go on to the next one. So which is your preferred exposure for revision total arthroplasty? So we have these various options: posterior, direct lateral, anterior anterolateral, trochanteric slide osteotomy, and the combined AP extensile. The trochanteric slide we know. The combined is what Harish talked about. You go both anterior and posterior. You don't disturb the gluteus medius. Okay. Right. Okay. So the posterior is quite predictably is high, but I want to add one word on the trochanteric slide osteotomy. I don't know what Neil thinks. We do it very, very commonly in revisions for your acetabular exposure. It's just like your rectus snip for your revision knees. We do our threshold is very low to do a slide. It's so easy to expose your acetabulum so fully. Once you do a slide, my answer would have been D, not.
Vijay, I have a question for you. So if you do that, do you change the patient's post-operative rehab?
Not really. We don't. No. Anyway, they are. We have put an acetabular component, femoral component. They're not going to be fully weight-bearing straight on. So it's part of the entire thing.
What about protecting them from active abduction? If you do a
No,
slide?
we don't protect them like that. No. As long as you keep the vastus lateralis sleeve intact, the medius, we have never had any problems, and the threshold is very, very, very low to do that. On your acetabulum, you can expose the entire both the columns so easily. So dislocation in THA. The commonest reason for dislocation of the hip I see when I revise for recurrent dislocation is, so this is what we want to know is what is the community where the errors are occurring. So is it acetabular malposition, the femoral malposition, the loose tissue tension, the abductor insufficiency, or impingement. Yeah. So can we vote, please, now? Wow. Very true, very predictable, yeah. So most of the things that we revise for recurrent dislocation is also because of acetabular malposition. For some reason, the community, the rate of acetabular, I don't know how it's in the US, but here the acetabular malposition is so common, almost invariable when we have a recurrent. Rajesh, would you agree on that?
Yep.
Yeah, please. Yeah. How's it in the US?
It's the same thing.
Same thing. So good. It's all same everywhere. Good. So what is the rate of dislocation after primary THA in your own practice? So we won't know who you are, so you can tell what it is, really is. So less than 1%, 1 to 2%, 3 to 5, 5 to 10, and greater than 10. As Jose was referring, the bald brown surgeon has got only 1%. But what about you? %, of 1 to 2%. That I think is very commendable, actually. It's much better than the US. Yeah?
Way better.
Yeah. These stats show it's way better than the US. Way better.
Is it better than Australia?
But if you ask the US surgeons, you'd probably get the same response because it's self-reported. You have to do an
Everyone would vote A.
Within the limitations of this, we are far better. Yeah. Okay. Well done, guys. Yeah. Okay. Great. So in your opinion, which factor is the most important for reducing the risk of dislocation after primary THA? I want to state that all these factors are important, but which is the most important in your opinion? That's what we want to know. The femoral neck, is there? Femoral neck length and offset, femoral head size, acetabular cup positioning, or the combined anteversion of runabout.
And please press the button till you see the green light on your voting pad. You should see the green light, not the yellow.
The combined anteversion. Wow. This is the impact ROC has had on our surgeons. I must truly say that. Is Amar here? Amazing. I mean, the ROC has been the most positive impact of arthroplasty in India. I must say that. Yeah.
Vijay, particularly because everybody thinks that acetabular malposition is the commonest cause of dislocation, and nobody wants to address that here.
Yeah, you could look at it that way as well. But
And one more thing is that 6% people are sleeping because they have pressed option E, and there is no option E.
That's also true. No, but jokes apart, truly amazing. Nowhere in the world would you have this. Would you have this combined anteversion as a thing? Bill, would you have it in an Australian poll like this?
Australians are aware of the concept, but I think they would have probably put acetabular component position.
Yeah, I think
first.
so. So, I mean, it's fantastic how the ROC has influenced a generation of arthroplasty surgeons in this country. Yeah. So, it's so important to take this tradition forward. Yeah. Fractures in THA, the commonest intraoperative fracture I see, this is with regard to unsymmetric femoral stem, calcar crack, femoral spiral fracture, trochanteric fracture, acetabular. We saw examples of all this. But what do you see in your own practice? Calcar crack, yeah. And then 3 is acetabular fracture, trochanteric fracture. Yeah, I would expect that. All are iatrogenic, some to do with approaches, learning curve, etc. All are iatrogenic, but calcar crack is the most benign of them. And
Can I make a comment on that?
Yeah.
We've been getting CT scans post-operatively to measure cup position, and when you do that, you find a lot of acetabular fractures that you didn't know was there. 1 in 20, maybe. But it's usually benign, and you don't need to treat it. But it's actually more common.
Yeah, more common than you think. Yeah. Arora, yeah?
So once you see them on CT, do you change the post-op rehabilitation?
No. I tell them if it doesn't hurt, they can walk on it. If it's a bit sore, they should protect it.
Yeah, Arora?
There's a paper published in CORE. The incidence is 5%.
Of?
Occult fractures, intraoperatively.
Intraoperative occult
detected
fractures.
post-operatively on CT scan.
5%.
Done for some other reason.
I agree that.
As a part of study.
We agree. So their incidence is probably higher than what you see, but as a benign, then that's fine, yeah. Okay, so we go on to the next one. Complications, yeah. So the commonest complication that you have after your primary THA is sciatic nerve palsy, dislocation, limb length discrepancy, or fracture. Quick, shall we poll on that? C is LLD. But
Expected?
yeah, so 17% did say dislocation, and then limb length discrepancy, fractures or only 4%. Yeah, that's good. Sciatic nerve. So we guys have seemed to have mastered protecting the nerve during surgery. Yeah, good. So this was one of the audience questions as well. My method to avoid limb length discrepancy is by the various things available. You check length by the femur GT position, the shuck test, check the limb length with other limb length, or use some kind of pelvifemoral measurements. The various jigs are available. So which is your method of choice? Poll, please. Check the limb length by, with what is that? With the other limb length. Okay. With other limb length. Yeah, there is something in the question.
That's why it's the commonest complication. Because that's not an accurate method. We use
that's something wrong in that
the
thing.
pelvic femoral measurement jig that we use.
So what would be your suggestion?
The point that we want to make was the shuck test is okay in revisions, where the limb length is not the priority. But if you go by shuck test in a primary THA, most likely that you will over lengthen them. Because people have different laxity and you can't reproduce the same tissue tension in everybody. Some people have lax and you must leave them lax. So that is the point that we wanted to make, but the C turned out to be a little wrong, yeah. Okay? No, that's okay, that's fine. So,
can I just say the pelvic femoral measurement jigs are not expensive or difficult to use. They're very cheap and easy. We use them for all of our posterior approaches, and they're good.
That's a very important point. So these days, we believe more on pelvifemoral measurement rather than absolute offset, vertical offset and horizontal offset. So my choice would be something that you have for a pelvic, and also we now accept a little bit of high hip center, things like that. So some pelvifemoral measurement may be the best way to go rather than absolute measurements. Shuck test will lead you around the wrong track. So that's the end of that. So thank you very much. I think that was very informative, the information given. Hopefully we can use it and put it in the use for the next conference. Thank you.